Fluid and medication administration with IV therapy. Intravenous access will provide direct access to the circulatory system, and this allows for rapid drug action. We can achieve precise dosage calculation and flow rates with IV therapy, and it avoids pain and tissue irritation from intramuscular or subcutaneous administration or oral drugs that can irritate the gastric mucosa or may be inactivated by gastric juices. The dose itself can be titrated to achieve a desired therapeutic response, and prescriptions should include uh, a continuous infusion, a flow rate that should not be listed as KVO, which stands for keep vein open, or TKO, which is to keep open. It should always be in mLs per hour or a specific volume over a specific time frame. It should include a route, the type and amount of solution, and any added medications, including the dosage. The prescriptions for an intermittent infusion should include the route, the solution or medication, and the amount or dosage, the frequency. It can be administered IV push, which is directly into the IV using a syringe, or IV piggyback, where we have a secondary solution container and secondary tubing. It can go directly into a continuous IV infusion or an intermittent device. Always be aware of the types of fluids and the expected outcome, and always verify compatibility of fluids and/or medications. Incompatibilities can cause precipitates in the fluid or a change in the action of the medications. If we have the precipitates, that can create an embolus. Infusions can be administered, again, continuously or intermittently. Solution containers might be a flexible plastic bag, a semi-rigid plastic bottle, a glass bottle, or a syringe. The glass bottles and semi-rigid containers may require an administration set that has a vent to allow air to enter the container and displace the fluid. The flexible plastic bag will have two ports, one for attachment to the administration set spike and one for injection of medications. Never use a permanent marker directly on the bag, as the chemical can actually penetrate and then bleed into the solution. Make sure you always use a label containing information per the facility's policy. A solution container should never hang longer than 24 hours due to the risk of bacterial growth. And understand that containers can come in a variety of sizes. 25 mLs to 1,000 mLs are going to be the most common. Always inspect the solution container to determine if there's any free or floating particles. It's not discolored, it's not expired, it's not cracked or leaking. And if issues are discovered, do not use it. Return it to the pharmacy. The pharmacy may receive a credit from the vendor, and we definitely will not charge the client for that damaged bag. Different types of solution will include the colloid versus the crystalloid. Crystalloids will contain electrolytes, etc., that may be dissolved in the fluids. Colloids are going to be the plasma volume expanders. They will pull fluid from the tissues and include things such as albumin, dextran, hetastarch, and mannitol. They are also considered your blood products. There are three types of infusion fluids: the crystalloids, We have isotonic, which will be similar to what our blood osmolarity already is. So that means when we put it in the vein, it's going to stay right where we put it. It's going to expand that blood vessel compartment. We will never administer D5W with increased intracranial pressure because the fluid will stay where we put it and it will only increase intracranial pressure. Nursing considerations: make sure that you watch for fluid volume overload. If it's staying in the vein, we're going to overload the client if we're not careful. Examples of isotonic fluids include your normal saline, your D5W, your lactated ringers, and then your colloids. Hypotonic solutions have a low osmolarity. So what it will do is pull fluid out of the vessel and put it into the tissue. So we'll use it for dehydration and hyperglycemia. It is contraindicated if we have increased intracranial pressure from a stroke, trauma, or neurosurgery, because again, we're pulling fluid into those tissues and it's only going to increase the intracranial pressure. There is a risk for what we call third spacing, especially with burns, trauma, or low serum protein from malnutrition or liver disease. Caution should be used with hypotonic solutions because it can cause cardiovascular collapse. We're pulling all of the fluid out of the blood vessels, and now there's nothing or minimal amounts of fluid to circulate through the cardiovascular system. So it collapses. Examples are going to be your half normal saline, your D2.5W, that's dextrose, 2.5% in water, or your 33% normal saline. Your hypertonic solutions have a high osmolarity. It's going to pull fluid out of the cells back into the blood vessels. We often give it postoperatively to pull fluids out of the tissues. It's going to help reduce edema and stabilize blood pressure, hyponatremia, and regulate urine output. So, we have these people that have been getting IV fluids, for example, in OR, and all of that solution is now in the tissue. We need it back in the blood vessels. So we give the hypertonic solution. It will pull the fluid out of the tissue into the blood vessel. So now we can pee it out. It is contraindicated if we have impaired heart or kidney function. The heart may not be able to handle that extra volume, or if we have impaired kidney function, the kidneys can now not get rid of that extra fluid, or it may be contraindicated in VKA. Considerations: again, we have to monitor for circulatory overload. Examples of these solutions will be your D5.5 normal saline, your D5 normal saline, D5 LR, and 3% normal saline. There's a variety of things that can actually affect the flow rate of an infusion unless it's controlled by an infusion device. The height of the fluid container over the client's heart: the higher the container, the faster the flow rate. The volume of fluid in the container: the more volume in the container, the faster the flow rate. The viscosity of the fluid: how thick is it? The cannula diameter: it makes sense that fluid will infuse slower through a smaller cannula. The venting of a fluid container: if we have a glass or semi-rigid container, the fluids have to be vented in order to flow appropriately. and the position of the extremity. And remember that if the tip of the IV catheter is next to or in a joint that bends, the flow is going to be significantly affected when that joint is bent. IV medication provides the best therapeutic effect. Once again, it can achieve a rapid therapeutic effect. It can be administered when oral intake is prohibited. It can eliminate pain or tissue damage that can occur if it's given intramuscularly or by mouth. But we cannot recall that medication once it's been given, and it's immediately metabolized. These IV medications can be given continuously or intermittently. Intermittently would be through an IV push or an IV piggyback into a continuous infusion or saline lock. There are some high-risk medications that require two nurses to check the dosage prior to administration. Double check the medication, the calculations, the dosages, and infusion rates with heparin, thrombolytics, insulin, narcotics, promethazine, and potassium. So nurses sometimes have to do admixing, which is the addition of a diluent or solution to a medication or a medication to an intravenous solution. This is usually done in the pharmacy, but due to the instability of some drugs, it has to be mixed just prior to administration. And it should be done in as few steps as possible to reduce the risk of contamination. Very important to limit distractions during preparation. Refer to the pharmacy, drug book, drug label, or the manufacturer's insert. Use aseptic technique. Consider that rubber stopper under the vial cap to be unsterile, so always cleanse it. Draw up the required amount of the appropriate diluent. We don't use pre-filled syringes for diluent. Inject into the vial to dissolve. We may gently agitate it by rolling it between our hands. We never shake it. Withdraw the appropriate amount of medication into the syringe and infuse as an IV push medication or inject into a 50 or 100 ml bag of compatible fluid for the piggyback infusion. So determine the compatibility of the medication and the fluids that may be infusing in a continuous infusion prior to administration. Again, if it's incompatible, it can cause precipitates or cloudiness. If it is incompatible, we have to flush before and after medication administration. I encourage you to do this regardless of whether it's incompatible or not. Scrub the port between every flush, medication, or infusion. So with IV piggybacks, once you determine that the medication to be infused is compatible with the primary solution, we'll prime that secondary tubing. Again, back priming is done after we connect it to the upper port by opening that roller clamp on the primary tubing and the secondary tubing, and then we lower the secondary solution container. Close that roller clamp on the secondary tubing when the drip chamber on the secondary tubing is about half full. Then we close that roller clamp and lower the primary solution container with that hanger or the hook in the secondary administration set. Connect the IV piggyback to the port that's closest to the drip chamber, of course after it's been disinfected, and infuse at the prescribed rate. With IV push, we never mix more than one drug in a syringe. We always have each drug in its own syringe, although sometimes we will mix those when we're doing intramuscular. We do not do this for IV. We always inject IV push medications in the port closest to the client. If we're administering more than one medication, we will always flush with normal saline between the medications, and we will cleanse the port prior to each syringe attachment. So if we have a continuous infusion going, we stop the infusion and/or clamp the tubing just above the port closest to the client. And I recommend doing this even if you have stopped the infusion. Keep that tubing clamped during medication administration to prevent backflow of the medication up the tubing instead of down to the client. So we cleanse the port, attach the saline syringe, always aspirate, then slowly push saline through the extension tubing and watch for any abnormal signs such as leaking or swelling or resistance or pain. We detach the saline syringe, cleanse the port, attach the medication syringe and inject at the manufacturer's recommended rate, detach the syringe, cleanse the port. Attach a second saline syringe and inject at the medication determined rate, because what's in the tubing at this point prior or just after injecting the medication? It's going to be the medication. We want to continue to inject what's left in the tubing at the determined rate. Once we have done this for all the medications, we will unclamp the tubing and restart the infusion. If we have a saline lock or intermittent device, we use the same steps as above, except we're going to unclamp the extension tubing prior to aspirating and flushing. We are going to flush the solution recommended for short peripheral catheters. The recommended solution is going to be normal saline. The flushing solution that is recommended for central venous access devices might be normal saline, but it might be heparin. So make sure that you're reading your orders. Our labels on our devices always include, on our medication syringes or secondary infusion set should always include the client's full name, the date, the name and amount of IV solution to be used to dilute the medication, the name and the dose of the medication, and the rate of infusion. So this will be once again on your secondary bags or your syringes that have medication in them. When you go in to administer the medication, you're going to do your 6 rights. Always identify your client with your 2 methods and check for allergies. And be familiar with the medication itself. What types of risks might be encountered with this medication? Is it a vesicant or does it have irritant properties? Explain the procedure to your client, assess the vascular access device system and function, and assess the medication container for leaks, contamination, and/or expiration. So then we move on to patient-controlled analgesia, or PCA. This is going to allow clients to control IV delivery of analgesia. The client basically will push a button and receive a dose of analgesia. There is a timing unit that imposes a lockout time between doses, and this will help prevent overdosing. So, in other words, the client will not receive any medication during the lockout time, even if that button is pushed. So basically what I'm talking about is the lockout time may be every 10 minutes. That's programmed into the machine. The client can push that button 100 times in that 10-minute time frame, but if excuse me, if that 10-minute lockout time has not passed, they will not receive any medication until 10 minutes has passed. Then they will receive one dose. They're locked out for another 10 minutes. The machine does have a lock on it to prevent tampering with the dosages, etc. It's used most often postoperatively or in clients that have chronic diseases, but these clients have to meet some requirements. They have to have severe, constant, or intermittent pain and an ability to understand and comply with instructions. They have to have that ability to press the button and not be sedated from other medications. Now, some clients can receive PCA analgesia, but they do require additional monitoring due to the potential for oversedation. So clients that have a history of sleeping disorders, respiratory or cardiac disease, kidney or liver failure, older adults, thoracic surgery, a lengthy duration of anesthesia during surgery, or morbid obesity are at higher risk for oversedation from the PCA, so they require closer monitoring. The nurse will monitor the respiratory rate, and we count it for 1 full minute, the quality of the respirations, the sedation level, and are there any respiratory noises? And this is done routinely with PCA use, in addition to the amount of drug that has been used and the pain level of the client. Advantages of the PCA: there's no IM analgesia administration. It is individualized pain relief, and there's decreased time between pain onset and medication administration. It provides the client with a sense of control and allows for night sleeping and decreased day drowsiness. Clients may actually require a lower amount of analgesia. The order or the prescription will require a loading dose. So how much are we going to give initially? What is that lockout interval? In other words, the client receives a dose, how long before they can receive another dose when they are pushing that button? Sometimes we will have a maintenance dose. We'll be giving a continuous dosage. We will have an individual dose. So every time the button is pushed, they'll be getting a certain amount. And they also have a maximum amount that a client can receive within a specified time frame. Occasionally, there's going to be an order for a bolus dose if the client has what we call breakthrough pain. In other words, the normal dosages are not controlling the pain sufficiently. The client should be the only one to control the button to deliver the analgesia. However, at times the nurse may do this. For example, I would hook up a PCA to a fresh post-op client while they were still in recovery, and because they're not fully awake but they are requiring pain medication, I would push the button for them. This can include an authorized agent-controlled analgesia administrator. This could be a nurse, a parent, or a caregiver, but those caregivers, the parents, will require education. We do double checks with the second nurse with PCA administration. Whenever we start a new PCA pump, we change the dosage or the lockout interval. or we replace a filled medication container with a new one. Complications of PCA: respiratory depression, anaphylaxis, nausea, vomiting, constipation. Think about it, they're getting narcotics, orthostatic hypotension, drug tolerance. So if there is a complication, we stop the infusion, notify the health provider, and prepare to administer oxygen and/or that opioid antagonist, more commonly known as naloxone. Routine monitoring, once again, respiratory rate for 1 full minute, quality of the respirations, sedation level and respiratory noises, how much drug was used, and what is the client's pain level. Another type of solution is parenteral nutrition. This will provide necessary nutrients and calories intravenously when the gastrointestinal tract can't or should not be used. It is customized for each client. LPNs cannot initiate TPN, but they can monitor it. TPN stands for total parenteral nutrition. It should always be administered through a central line. Conditions that we might use TPN for is a debilitating illness that has lasted over 2 weeks, critical illness, organ failure, deficient or absent oral intake over 7 days, a loss of 10% or greater of the pre-illness weight. We have a serum albumin below 3.5 grams per deciliter, poor tolerance of enteral feedings, where the feeding goes directly into the stomach, chronic vomiting or diarrhea, an inability to sustain weight, or GI disorders. That solution is, once again, developed individually to meet the client's needs, but it can also contain dextrose, proteins, electrolytes, vitamins, trace elements, water, and/or lipids, and not necessarily all of those, but any mixture of those different ingredients. Risks with TPN include infection. This is a very high calorie, high glucose solution. So we can also have hyperglycemia and hypokalemia. We should always warm the solution for about an hour before we administer it. Check your order, determine the patency of the IV site, and use strict aseptic technique. Change that solution and administration set at least every 24 hours or per your facility protocol. Monitor vital signs at initiation and every 48 hours. Monitor glucose levels routinely, and monitor the client's overall status. We should never discontinue it abruptly, but we should wean it over 24 hours. The solution container might be more frequent per facility policy when we change it, but once again, at least every 24 hours. Vesicants are drugs that are especially toxic to the subcutaneous tissue. In other words, if these drugs infiltrate into the tissue, they can harm the subcutaneous tissue. Central lines are preferred to administer vesicant solutions, but they're not always available when needed. If a vesicant is infused in a peripheral line, that site needs to be monitored at least every 5 to 10 minutes. To reduce the risk of extravasation, we use the largest vein available, but the smallest appropriate cannula. Ensure that cannula placement is good prior to the administration of a vesicant, and flush the cannula after a vesicant is administered. If that solution extravasates, aspirate the vesicant prior to the removal of the catheter. That prevents any vesicant still in the catheter from causing further tissue damage. It does require discontinuance of the site and may require an antidote be injected around the extravasation site to minimize tissue damage. And always notify the provider. Common vesicants include vasopressors, potassium chloride, and your anti-neoplastic agents. And now we have your post-test.